course, since the very beginning, when we first started getting alerts around Ebola, we started to prepare for what we would do in case an Ebola patient presented here. And so there's two ways potentially an Ebola patient could come, and either one is by ambulance or the other one is that they could be walking in. So we had to have a system that would facilitate both. So we worked very closely with the Ministry of Health has sent directives to all hospitals telling us what we must do and what we must have in preparation for just in readiness. You know, there was lessons learned from SARS, and when they're not going to make mistakes take place. So what has happened was that the first thing that we did was that we put together a whole kit of all of the supplies that needed to be necessary, and developed a process as to what was going to happen if a patient came here. It was also identified that to protect the nursing staff from a patient that was coming into the hospital, there either had to be a protective barrier before screening was done, or staff had to wear a complete set of the protective gear, which means the gowns, the masks, the goggles, the whole bit, which is to work hours and hours, and this is very uncomfortable, it's very hard. So we thankfully have a glass partition, so right now we're in the processes of anybody that comes in, so there's signage at all doors, there's extensive signage at the emergency entrance as you're coming in, and it's asking people to identify whether they have been traveled and out of country to Africa, within particular the areas within the last 21 days. And until that happens, we keep the glass shut. We are getting a microphone, except the microphone has broken 2 windows as they were trying to install, so I had to go to the factory. So right now it's a little cumbersome as we're talking through glass, and it seems very not patient focused when you're yelling through. But anyway, we are managing, and people are very understanding of that, so that's great. So what happens is that a patient comes in, and every single patient that comes in the door are asked if they've traveled and whether they've had a fever. And as soon as they identify they haven't traveled to Africa, that we can open the glass and we can speak to them so that they can properly hear us. And then we do the triage process. If a patient identified that they had been to Africa and they had a fever, immediately we would take them to what we call room 11, which is our negative pressure room. And they would go in that room, and we would shut both doors to activate the negative pressure. Even though Ebola is not airborne, Ebola is only really very contagious at the end of life, when there's a lot of secretions that are being from the body, and after life, it lives on after death. So, you know, really, if a patient came in with a mild fever, they probably wouldn't be that contagious, but that doesn't matter, we're still going to do the same thing. So to protect nurses, what would happen is that 2 nurses would immediately have to take care of that patient, which means that they would have to don all of the equipment, and one person's watching the other one. They're making sure that absolutely no skin is exposed whatsoever. And then they would go into a room to care for that patient. That's if they come in walking. If they come in, and then before I go to the ambulance patient, is that what would happen is before we can't take any blood work from an Ebola patient, because that would literally shut down your lab. So the first thing that we would do is that we would notify public health, and we would also notify an infectious disease specialist at the Ottawa Hospital or CHEO, because there's one at each, depending on the age. Under 18 would be CHEO. And then what would happen is that we would follow their directions as to what would need to happen. And so there would be, the second thing that would happen from an ID perspective is they would go into a very extensive secondary screening to find out how high the risk factor was, and whether they really truly were at risk for Ebola. And so the screening tool would be whether they were involved, whether they were a healthcare worker, even to the point of whether, you know, they had been in an area and were consuming the meat products of that area. That would be risk for potential transfer. So that being said, we would follow what the direction was from the infectious disease person and then make arrangements to transport. So all of the nursing staff here have gone through donning, doffing exercises. We have been involved in weeklies or sometimes bi-weekly meetings to get up to snuff. So now we're sort of in a status quo where we're just getting ministry updates. If a patient was to come by ambulance, we're still in what they call a draft right now that should be resolved within the next couple of weeks, but we're looking to do an Ebola bypass. So a patient that would be coming, so 911's called and dispatch does a first screening. If the first screening, the patient sounds like they may be potential for at risk, then they do a secondary screening. So that secondary screening would be the kind of questions that infectious disease specialists would ask. And the whole point of that is so that they can ensure that if a patient's going to be at very high risk, that of course the paramedics that are going in are going to be properly protected. So if that patient can safely be transferred because they meet the criteria, they would go either to the general or the CHEO. If the patient was having, let's say, a heart attack, a stroke, or a trauma which they wouldn't be able to answer the screening anyway if they were coming from that, they would come here, but the plan would be is that they would be assessed and we would do what we could without having to decant them out of the ambulance. So the emerge physician would try to do it so that we're not contaminating the whole unit. And then what would happen is that we would again call infectious disease specialist at the hospital, would make arrangements to transfer. Because let's say, for instance, we have what they call, and I think I've talked about this before, we have a protocol for if somebody comes in with a heart attack here, we have what they call a STEMI protocol, STMI protocol, which bypasses us very quickly. We just confirm that yes, in fact, the patient's having a heart attack and they go up to the Heart Institute. Well, if we were to send an Ebola patient to the Heart Institute, you can imagine the travesty that would happen because that patient had gone there because it would shut everything down. So, you know, there's all sorts of things. Saying that, we know that there is extremely low risk of ever having an Ebola patient. The last meeting that I went to, there's about 25 patients a week that are coming from the regions that are coming in all over Ontario, and they're very low risk of having.
It's so funny.
There has been